Hi, this is Brian Kim. I want to share with you case number 178 in the best way to do cataract surgery series. This is a patient with a cataract, and you're going to see double chop, cross chop mechanical fracturing. And in this case, you could argue I could have performed terminal chop. You can see here when I do the double chop and cross chop, and there's jigsawing of the lens pieces, I'm able to utilize a technique that I've been calling scissoring chop, where you're able to amputate the posterior adhesion by turning the chopper sideways. And you're going to see how easily I'm able to disassemble this lens despite having a very dense lens and being able to tackle the posterior plate. So this is the corneal marker, which will help me to center in Scissorhexis. I'm using the cotton tip to steady the eye. And this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to the iris plane, which will allow me to create a nice corneal shelf and allow me to achieve a self-sealing incision. This is intracameral lidocaine and then some intracameral epinephrine and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And then using the cannula to control the eye, this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I turn the eye towards me and then I enter, using the cannula to control the eye. And these are the sharp tip Haldey-Perkar forceps. I'm going to puncture the center, pull down towards me. The tear's going a little bit to the left side, so I grab the tear and then create a flap, going around circumferentially, and then trying to make the rhexis match the corneal mark that I made previously, which will hopefully give me a well-centered and sized rhexis. You want to keep the forceps straight up and down as much as possible and not put any tension on the wound, which will help minimize any OVD egress, which will reduce destabilization of the chamber. This is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, get a nice wave, decompress the lens, sweeping on the left side, and then rotating the cannula tip down on the right side, and the lens begins to spin. Again, with dense lenses, they tend to have weak zonules, so I keep that in mind with each of these cases. Lift the incision with a chopper, go in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material, bevel down and place the chopper under the rhexis edge, leading with the tip. Turn the chopper vertically, placing the phaco-tip vertically, sub-incisionally, bringing the instruments together, crushing the lens completely in half. That is the double chop maneuver. Turning the chopper flat, sliding it under the right heminucleus, turning it vertical, pulling it centrally towards the phaco-tip, fracturing the lens against the phaco-tip, and that is the cross chop. I'm using the phaco-tip like a chopping block in that situation. And then I place the chopper around that first quadrant, pulling it centrally toward the phaco-tip, fracturing that piece in half, and then using some vacuum to lift that first fragment up, and then turning the chopper sideways, and that is a scissoring chop maneuver, amputating the posterior adhesion of that very dense lens. So I'm going to show this again in slow motion. You see I'm leading off with the tip, pronating my hand, sliding the chopper underneath the rhexis edge, turning it vertically, turning the phaco-tip vertically sub-incisionally as well, bringing the instruments together, fracturing the lens completely in half. Separating the lens. There may be some posterior adhesions, again, because this is such a dense lens. Again, sliding out the chopper flat, so it slides underneath the rhexis edge around the right heminucleus, turning it vertical again, making sure it's out to the equator, pulling it central toward the phaco-tip, hooking the peripheral lens, and then crushing the lens against the phaco-tip. Using some vacuum to grab that first piece up, that first quadrant up, and as I lift it up, I'm able to place the chopper around the lens, bringing the chopper towards the phaco tip, again, fracturing the lens again into two pieces there, that first quadrant in two pieces, using some vacuum to pull that fragment up, crushing it once more, and then using some ultrasonic energy to remove that lens piece. And then using some more vacuum to pull that fragment up, turning the chopper sideways, amputating the posterior adhesion, and that is the scissoring chop maneuver. This makes sure that that piece is completely disassociated from the rest of the lens. And now I'm able to use some vacuum to hold it, and then I crush the lens between the instruments. I use some vacuum to hold it, crush the lens between the instruments, and then emulsify the lens piece. So now that first quadrant is pretty much gone now. I'm going to slide the chopper underneath the second quadrant, pulling it centrally toward the phaco tip. Again, the phaco tip is fairly deep. Again, this is a fairly dense lens, so you should keep that in mind. Lifting that first piece up with some vacuum. Once I lift it up, I get the chopper underneath it, turning the chopper sideways, again, amputating the posterior adhesion there. And so when you have this very dense lens and you feel like the lens is still jigsawed together, you can do that scissoring chop maneuver, which is really quite effective here. I'm trying to grab that first piece up, but then with the chopper, but then I grabbed it with some vacuum and then emulsified the lens piece there. So again, a very dense lens, a lot of adherent lens material, jigsawed all together. Again, there is a posterior plate in this situation. Now I'm trying to rotate the lens and the lens won't spin. You saw after hydrodissection, I was able to spin the lens, but nonetheless, it's not spinning here. And so now I switch to the cannula and I'm going to do some more hydrodissection. So whenever you're in a situation where you're not able to hydrodissect, you can always go back and hydrodissect once more. Go back in with the phaco tip and the chopper again. And when the lens is difficult to spin, again, it gives you a sign that perhaps there is some zonulopathy. Start to rotate the lens. You see the lens begins to spin a little bit. I use some vacuum to grab the lens piece and help kind of turn it a little bit. You saw that maneuver with the phaco tip. And then I'm going to try to slide the chopper underneath the rhexis edge. I stop and then I go one more time, just making sure I'm definitely underneath the rhexis edge. I have the phaco tip deep. Bring the chopper towards the phaco tip, fracturing the lens in half. Using some vacuum to pull that fragment up. Once it's up, I turn the chopper sideways a little bit, and then I'm able to crush the lens again. And then now this is a scissoring chop maneuver. I'm getting around the lens, underneath the lens, crushing the lens. And that's the benefit of chopping in this way. You don't have to make the chopper straight up and down. You can turn it sideways, and you can amputate the deeper adhesions, and that's what you're seeing there. Still a rather stubborn lens that doesn't want to spin, so I'm using some vacuum to grab it a little bit and twirl it, and then now it's turning because I grabbed it with some vacuum, and now I get the chopper around the lens and then fracturing it completely in half, and then placing the chopper around that quadrant and then fracturing it again in half one more time. Using some vacuum to lift that fragment up, and then this is again that scissoring chop, getting around the lens with the chopper underneath it, and then amputating it sideways. So it's a scissoring chop, scissoring maneuver. It's a sideways maneuver. It's not an up and down chop maneuver. So by doing it this way, you're able to basically chisel away at the lens piece, and you are going to have a posterior component to this lens, but this is a very efficient way, an elegant way of dealing with the situation where you have a very dense, deep lens component like the posterior plate. You'll be able to amputate and separate the lens pieces very easily with this scissoring chop technique. So again, in order to get a through and through chop, I think terminal chop or some type of technique to debulk the central dense nugget is a more efficient way to handle that and deal with that. But if you kind of underestimate the density of the lens and you try to perform the double chop like I did, and you feel like you're not all the way through and there's some still posterior leathery adhesions, you can still disassemble the lens very confidently and efficiently by performing these scissoring chop maneuvers. And again, the nice thing about it is you can turn the chopper sideways, as you see here, get underneath the lens, amputate that posterior adhesion, and it breaks that lens piece off from the rest of the lens, and then you can emulsify it. Because that's the hard part with these situations. When they're all jigsawed together, even though you try to eat the piece, it doesn't effectively get emulsified because it's all stuck together with the rest of the lens. By doing the scissoring chop, you're able to effectively amputate the lens from the rest of the lens and then be able to remove it without trouble. So you can see again, using a lot of mechanical fracturing forces, crushing the lens over and over and over again, and using pulses of ultrasonic energy in the process. Again, sparing amounts of ultrasonic energy in order to help break down this very dense lens. Again, using crushing forces between the instruments to emulsify the lens piece as I do this. I pretty much got all the endonucleus out, and now I'm dealing with the epinucleus. Because this is such a dense lens and I know that the zonules might be weak, instead of going after the epinucleus with the phaco tip, I go ahead and come out and I switch with the INA handpiece. And there you go. So I was able to use high vacuum, and that removes all the epinucleal material. I went in and out quickly right there because there was some lens fragments there. And when I went out, I knew that the rest of that lens piece was going to come out when I came out with the INA handpiece. Go ahead and start polishing underneath the rhexis edge, removing the lens epithelial cells. And oftentimes when you have a lens that doesn't spin very well, I've noticed that the lens, including the cortex and the epinucleus, endonucleus, all kind of adherent to the bag. And so when you remove the cortical material, sometimes, like in this case, it just kind of comes out all in one fell swoop. Pulsing into the subincisional capsulorhexis with the BSS cannula. And this looks pretty clean, actually. Pushing cohesive viscoelastic to fill the capsular bag. And then we'll go ahead and polish underneath the rhexis edge with the sweep. Again, the purpose of the sweep is to polish any lens epithelial cells and go after any remaining cortical strands, especially in the subincisional area. This is a single piece acrylic lens. It's going into the capsular bag. The leading edge is going into the bag as the lens unfolds. I quickly switch to the INA handpiece, go in with irrigation off, activate irrigation, making sure the haptics are off the optic. Going underneath the optic, tilting and rotating at 90 degrees clockwise, removing all the viscoelastic from within the bag. Making sure I remove any fine lens material that might be within the bag as well. And then I switch to polish mode, polishing under the rhexis edge, and then I'll hydrate my incision. So again, this is a patient who had a Catarock. In this case, I performed direct double chop, cross chop. It didn't get a complete chop all the way through. There was a little bit of a Pac-Man effect, i.e. the posterior plate, but rather than having to switch gears and do a different technique, I went ahead and performed the scissoring chop maneuver. As you saw, the scissoring chop maneuver allows you to amputate the posterior adhesion. Basically, you lift that fragment up with the vacuum and then turn the chopper sideways, get underneath the lens now, bring the chopper and the phaco tip together, and it will amputate the posterior adhesion of that lens fragment. So again, if you want to think about a posterior plate like the center part of the flower and the petals of the flower are all the lens fragments that haven't come apart, you can pull those petals off the central core of the flower by doing that scissoring chop maneuver. So the scissoring chop maneuver is very effective, very efficient, being able to amputate the posterior adhesions in this situation. Again, alternatively, you could perform terminal chop or some alternative where you debulk the central dense lens and thereby being able to crack through and avoiding the posterior plate, But in these cases, when you already got started, instead of having this very difficult and frustrating posterior plate situation, you can still fracture the lens as you've seen here. And then if there's any deep adhesions, again, you can perform that scissoring chop, turning the chopper sideways, getting underneath the lens with the phaco tip, and then crushing the lens between the instruments, and then very carefully and easily conquering the posterior plate with this scissoring chop maneuver. So I hope this was helpful to you, and I thank you for your attention.